Hello, everyone, and welcome to today's webinar, CT First Imaging, Rethinking Chest Pain Evaluation and Atherosclerosis Detection. My name is Saili Tarlekar, and I'm the Global Head of Marketing at Erineta. It is always a pleasure to be among friends and champions of cardiac CT. Erineta is fully committed, passionate, and dedicated to advancing cardiac CT. I'm so excited to have you with us this afternoon. We've had an incredible response and fantastic attendance again this year, and we're thrilled you've taken the time to join us. Today, we have two distinguished speakers who will discuss some insightful topics. It is my pleasure to introduce Dr. Sujit Kalativital. He is the Director of Cardiac Imaging at Dooley Health and Care, a large multi-specialty practice in the Chicagoland area with more than 1,000 physicians, including over 50 cardiologists. Dooley acquired its first Erineta cardiac CT scanner in 2021 and expanded its program with a second scanner earlier this year. Dr. Sujit also serves as Director of Cardiac Imaging at Advocate Good Samaritan Hospital and as Co-Director of Cardiac Imaging at Northwestern Medicine Central DuPage Hospital. Today, he will be speaking about the role and clinical utility of cardiac CT in the urgent care setting. Welcome, Dr. Sujit, and we're so glad to have you with us.
Saili, thank you for the kind introduction. I'm going to go share my slides. Sorry, let's try that again. There we go. All right, so good afternoon, everyone. I'm Sujit Kalativital. I'm a cardiologist at, as you heard, for Dooley Health and Care. And this is my presentation, which is coronary CTA in the urgent care setting, a CT-first approach to chest pain. So I wanted to speak a little bit about my organization, Dooley Health and Care. So we are a private physician-owned multi-specialty practice with 1,000 physicians and roughly 50 cardiologists. And we offer a range of services across both primary and specialty care and serve about 2/3 of the Chicagoland suburbs. Our core philosophy at Dooley is to provide high-quality care that is outpatient-based and cost-effective. A lot of that is driven by the fact we have a large managed care population. So, knowing that chest pain was historically a major problem for our practice, particularly with our primary care providers, our triage nurses would reflexively send all patients with chest pain to local emergency rooms where they were typically admitted for inpatient evaluation. And many of these patients did not have life-threatening chest pain, so hospital admission was unnecessary and would basically create a large cost to the patient. So to address this issue, we created a cardiac evaluation center, also known as a CEC, for patients with non-life-threatening cardiac symptoms, including chest pain, provide rapid evaluation and on-site testing. And by doing this expedited outpatient cardiac evaluation, we are able to reduce healthcare costs and improve patient experience. So I think everyone here is very familiar with this document. This is the 2021 AHA-ACC chest pain guidelines. And in the guidelines, coronary CTA or CCTA is the only test with a class 1 recommendation and level A evidence for the diagnosis and management of stable chest pain in patients without prior obstructive coronary artery disease. So when these guidelines came out, it became very clear acquiring our own CT scanner was vital to our practice. So we purchased an Erineta Spotlight scanner and actually went live with the scanner in January of 2022. So we chose the Spotlight for a variety of reasons. First is its smaller form factor. It's very space efficient, which makes it great for an ambulatory setting or an office setting. Second, the smaller field of view to a cardiologist is actually a plus. It reduces radiation dose and limits visualization of non-cardiac anatomy. It's a true dedicated cardiac CT scanner, though there are larger field of view applications available. It's cost efficient compared to larger detector scanners. It still provides excellent image quality. So I want to just review kind of our triaging system that we use for our nurses at our CEC when they're contacted by a patient with chest pain. So the first thing they do is they speak to the patient and find out, is the patient having severe chest pain? And the ACC actually does have definitions for what's severe chest pain. That's 8 or greater out of 10 if it's described as crushing or if there's a sense of impending doom. Any of those things, the patient is recommended to contact 911 and have EMS activated. The next question they're asked is, does the patient have a history of prior obstructive coronary artery disease? Has the patient had a prior myocardial infarction? Have they had a stent placed before? Do they have a history of prior bypass surgery? If the answer is yes, and if these are the same symptoms they had prior to their ischemic event, yeah, they're again instructed to call 911. Finally, we do screen for COVID. We ask the patient if they've had fever, cough, or COVID positive in the last 10 days. And if the answer is yes, they go to the emergency room. We find that the majority of our patients don't say yes to these questions, and they are then directed to our cardiac evaluation center for evaluation. So our CEC is open Monday through Friday, 8 a.m. to 5 p.m. And in addition to the walk-ins, we have 12 elective outpatient cardiac CTs that are scheduled every day. These are a combination of coronaries, pulmonary vein / appendage studies, valve CTs for structural heart interventions, and thoracic aortas. In addition to these 12, we have these 6 additional walk-in slots for patients who present to our CEC with chest pain. A typical day, we do 2 to 3 walk-in CTs on top of the 12 we have scheduled. So our average is 15 cardiac CTs per day. I'm at the CEC every Friday, and unfortunately, I have ordered as many as 6 walk-ins on a given day. So I think our technologists, they're prepared to do some extra work when I'm there on Fridays. Um, at the CEC, we have it staffed by 1 cardiologist and 1 cardiology nurse practitioner. So between me and the APN, we're typically seeing 16 to 28 patients per day at our CEC. These are our volumes at our CEC. So the left side of the screen shows our patient encounters. So our very first year that we opened in 2022, we saw about 1,600 patients. Second year, we ramped up significantly and saw about 2,700 patients. 2024, 3,100 patients, and this past year, 3,300 patients. Our CT volumes accordingly have also risen significantly. So our first year, we did about 1,600 CTs. Our second year in 2023, we did about 1,800. Then you can see this big jump up between 2023 and 2024. We hired a second technologist. So with 2 technologists, we were essentially able to double our volumes, and we're up to 3,300 scans in 2024. And this past year in 2025, with 1 scanner and 2 technologists and a nurse, we did 3,700 scans. We just went live at the beginning of January, actually, with our second cardiac CT scanners. So I think we'll see another big jump in volumes in 2026. I would also point out, despite these high volumes, we still maintain a very high quality CT program. So we've been partnering with HeartFlow since the day we opened our CEC. We actually offer FFR CT as needed in all the patients who get scans. At our CEC, we're also participate in plaque analysis and roadmap. HeartFlow gives a quality award if you have a 90% or greater approval rate when you submit coronary CTAs to HeartFlow. We have gotten the HeartFlow Quality Award every quarter since opening. So that's 16 consecutive quarters, which is the highest approval rate in our geography. I wanted to go over 5 case studies. These are patients who actually presented to our CEC and kind of highlight how CT helped us evaluate and treat these patients. Our first patient is a 60-year-old male with well-controlled hypertension, hyperlipidemia, who exercises regularly. Notably, his mother died of a myocardial infarction at the age of 61. So he recently went on a family trip to Michigan. He walked a 3-mile hike with the incline. After walking about a mile uphill, associated with chest tightness. He rested for about 15 minutes with resolution of his symptoms. He completed the remainder of his hike, which was downhill without incident, and his symptoms did not return. He contacted his primary care physician the next day, and then he was referred to our cardiac evaluation center. So when he arrived at our CEC, he was in sinus bradycardia at a rate of 53 beats per minute, which, as you all know who read cardiac CT, we love bradycardia. Labs, including a troponin, were checked, which were normal. So given that his heart rates were already controlled, we performed a coronary CTA 30 minutes after he arrived. And here's what we found. So first, again, because the smaller field of view and this patient had, reasonable body size, we actually used 100 kVs for the scan. And you can see our radiation dose was only 2.4 millisieverts. We found the patient had a 70 to 99%, so obstructive disease with mixed plaque involving the proximal LAD. Again, we perform FFR CT on these patients. We found that he had a hemodynamically significant lesion in the proximal LAD, also affecting flow in the second diagonal branch. The patient was started on aspirin and nitrates. We did not put him on a beta blocker because his heart rate was already in the 50s and he was discharged. He spent a total of 1 hour and 45 minutes at our CEC, and then he underwent a cardiac cath 2 days later, which showed a 90% proximal LAD lesion. Elective PCI was performed. He had a drug-eluting stent placed to his proximal LAD and was discharged the same day. So then this is our second case. This is a 27-year-old male without any obvious cardiovascular risk factors. He had an LDL of 94, does not have diabetes, he's a non-smoker. But interestingly, and this was during the pandemic, 1 month prior to the presentation, caught COVID-19. He was unvaccinated. He had moderate symptoms, fevers and cough for 3 days. After he recovered from his febrile illness, he noted intermittent chest discomfort that radiated to his left arm. He described it as a substernal tightness, and he only felt these symptoms with exertion. Walking up a flight of stairs, he had no symptoms at rest. And again, I'm just going to tell you how things played out. He relayed these symptoms to his primary care physician, who ordered an exercise stress echocardiogram. Again, if you had seen me with exertional symptoms, to me, that's an abnormal stress. That's equivalent. I would have proceeded directly to coronary CTA, but a stress echo was ordered by his PCP. And this is what it showed. So his resting EKG was completely normal. And 8 minutes into exercise, he developed 2.5 minutes of flat ST7 depression, which completely resolved 5 minutes in recovery. Baseline echocardiography showed normal left ventricular systolic function and wall motion. His ejection fraction was 60%. Stress echocardiography showed exercise-induced hypokinesis of multiple segments, which corresponded to a proximal LAD distribution in terms of stenosis. And notably, he did get 6 out of 10 chest pain with exercise that completely resolved in recovery. So given these dramatic findings, the patient's primary care doctor was contacted by one of my partners, who was the reading cardiologist. And as the patient's EKG changes and symptoms had resolved completely, the patient was sent to our CEC for same-day evaluation. I just want to be clear, if the patient had persistent EKG changes or chest pain, we would have activated EMS and had the patient go. But again, everything resolved. So the patient came to the CEC. Upon arrival, they were given this kind of very concerning story. An EKG was done, which was normal. Labs were checked, including a troponin, which was normal. So a coronary CTA was performed an hour after arrival. And interestingly, this is what we found. We found evidence of a dissection involving the proximal LAD, and there are case reports of this occurring in post-COVID patients. And notably, there was no evidence of atherosclerosis or calcification in his coronary arteries. We did perform FFRCT, which again showed a hemodynamically significant lesion in the proximal LAD. This patient actually had a spiral dissection, so you can see this kind of rainbow pattern of flow working its way all the way down, and tapering off as we go further and further down the LAD. He spent a total of 2 hours at our cardiac evaluation center getting all of this testing performed. The patient was then started on antiplatelet therapy and beta blockade and observed for 48 hours in the hospital. He was seen by cardiac surgery, who agreed with conservative management because, again, this patient was really chest pain free at rest. His symptoms only occurred with exertion. After 2 days of observation in the hospital, he was ultimately discharged home with instructions to avoid heavy exertion for 30 days. And a repeat coronary CTA a month afterwards showed healing of his dissection, and he was referred for phase 2 cardiac rehabilitation. And if you think about this, if this patient had a stress test and proceeded directly to cath, we know cath can be very dangerous in these patients with coronary dissections. You can actually propagate the dissection and worsen things. So again, using coronary CT allowed us to safely get the diagnosis. Our third case is a 59-year-old male with a history of elevated coronary calcium score at a score of 804 in 2020, who has noted intermittent substernal chest pain for the past 2 months. The primary trigger for this pain is emotional stress. He does have severe arthritis of his right knee and has been less active, and he cannot run a treadmill. So a resting EKG was obtained, which did show he had developed a new right bundle branch block. His PCP saw these findings and ordered a Lexiscan SPECT stress test. Again, this is what the PCP ordered. This showed no ischemia and ejection fraction of 57%. So the patient was reassured by his PCP. Despite this, his symptoms, never went away and actually steadily increased in frequency over the next month. So he was ultimately sent to our CEC for further evaluation. Upon arrival at the CEC, labs, including troponin levels, were checked, which were normal. So given his new right bundle branch block and recent normal stress test, D-dimer was checked, and this was found to be normal, and we wanted to rule out pulmonary embolism. So we ultimately then proceeded with a coronary CTA 45 minutes after arrival. And here's what we found. So we found that he had moderate diffuse disease in the proximal and mid LAD. And if you kind of hallucinate with me, if you look way down at the distal LAD, you can see a severe stenosis really right around as the LAD wraps around the apex. Non-obstructive disease was noted in the circuit RCA. And again, I would point out to you, this was a slightly larger patient. We used 120 kVs, 3.8 millisieverts of radiation, still a very low amount. And here's the FFRCT on this patient. Again, you can appreciate, again, as we kind of near the distal line of the LAD, there is a very focal drop in flow right at the very end, consistent with the focal stenosis, right at the distal tip of the LAD. And you can see how this would be readily missed on a nuclear stress test. So the above findings were discussed with the patient at length, and aggressive medical therapy was recommended given the very distal location of this stenosis. So he was started on beta blockers and nitrates and discharged with outpatient follow-up, and his symptoms improved a week later, and he spent a total of 90 minutes getting this testing done at our CEC. So our fourth case is a 67-year-old male with morbid obesity. One of the challenging groups of patients we deal with for coronary CTA at a BMI of 51, diabetes, hypertension, hyperlipidemia, and he's reported mild intermittent chest pressure that's been going on for the past year. It occurs at random with or without activity. He also notes chronic dyspnea upon exertion that he attributes to obesity and deconditioning. So in 2017, he had a Lexiscan SPECT stress test done, which showed anterior wall ischemia. He actually underwent a cath at that time, which showed mild diffuse non-obstructive coronary disease. And it was thought that, these findings on his stress test were just due to shifting soft tissue attenuation, and it was artifactual. So he was referred to our CEC for evaluation, and upon arrival, he was noted to have two things. One, a blood pressure that was normal, 130/80, but a heart rate that was 88. Labs showed a negative troponin, EKG showed low voltages with non-specific T-wave abnormalities. So when we scan these larger patients, so with a BMI of 40 and above, we actually do have a large patient protocol at our CEC. Specifically, we reduced the rotation speed on our scanner from 0.24 to 0.27 milliseconds. And we've experimented with 140 kVs. We find that 120 kVs still works pretty nicely. The problem with the 140 kVs, from my experience, is we just lose a lot of the contrast attenuation. So we really focus on lowering the rotation speed to improve penetration of X-rays in the patient. The problem is when we do this, we're sacrificing temporal resolution. So we work around that by shooting for an even lower heart rate. We try to target a heart rate of at least 60, ideally less if possible, to make up for the slower rotation speed. So given that his heart rate was 88 and we knew that, he's a large patient, getting him rate controlled in a timely fashion was likely not going to be a winning battle. So we actually discharged him after 50 minutes and we planned for him to return the next day with pre-medication for rate control. He was prescribed metoprolol tartrate, 100 milligrams that night and the morning of his scan. And when he came in the following day, his heart rate was 74 beats per minute. He was given an additional 100 milligrams of metoprolol tartrate as well as 15 milligrams of oral ivabradine or Corallenor, which is a great drug. It just works really slowly. So we waited 2 hours later, and ultimately his heart rate was 60 beats per minute, and coronary CTA was performed. And there's a lot to unpack here. His left main showed mild distal disease. We saw borderline significant disease in the distal LAD as well as second diagonal branch, so 50 to 69%. Mild disease in the proximal and mid LAD. His circ showed, again, possibly significant disease, 50 to 69% of the proximal circ and OM1 branch, and possibly significant disease in the mid RCA. So again, 50 to 69%, and mild disease in the proximal and distal RCA. So, if we had just had coronary CTA, we would still be struggling to kind of make heads or tails of this information. But FFRCT, again, gives us a very nice kind of roadmap in terms of how to tackle this. So FFRCT confirmed that the mid-RCA lesion was hemodynamically significant. The second diagonal branch lesion was hemodynamically significant. And there were significant drops in flow in the distal LAD and distal OM2. So he subsequently underwent a cardiac cath, which showed a 80% mid-RCA lesion, 90% ostial second diag lesion, 80% distal LAD and distal OM2 lesions. So a drug-eluting stent was placed to the mid-RCA. He had just plain old balloon angioplasty of the second diagonal branch. We didn't want to risk jailing the LAD with a stent there, so it was just angioplasty successfully without any significant shifting of plaque. And given the distal disease in the LAD and OM2, we made the decision to treat those medically. So again, both the combination of coronary CT and FFRCT really helped us, unravel the mystery of this patient's coronary anatomy. Our final case is a 74-year-old female who's presenting with chest pain. She has a history of rheumatoid arthritis, hypertension, and hyperlipidemia, and a calcium score that was 900 back in 2005. And she has been on high-intensity statin therapy since this time. So we know that statins cause plaque to calcify and shrink to an extent. So one can only imagine what her calcium score is now since she was on high-intensity statin therapy for the past 20 years. So she has a long-standing history of GERD, which manifests as heartburn after eating. But over the past couple months, she's noted that her heartburn occurs sometimes without eating and even with exertion. So she was referred to our CEC for further evaluation, and she came in on a Friday afternoon. And as I pointed out earlier, I'm the Friday afternoon physician at our CEC, and I have a notorious black cloud. So she showed up, of course, on Friday afternoon with her daughter, who was a physician who was very concerned about her symptoms. EKG was normal. Troponin was also normal, and her heart rate was 58 on arrival. So a coronary CTA was performed. So this is what we saw in our coronary CTA. It showed heavy calcification of the distal left main, extending into the ostial LAD and circumflex, and also in the proximal LAD itself. Um, we really couldn't accurately see the lumen of the vessel because of the amount of calcification. I could see that there was non-obstructive disease in the mid LAD, circ, and proximal mid RCA. And again, she was a thin lady, so we used 100 kVs and only required 1.9 millisieverts of radiation. So we then did FFRCT, and FFRCT, it's really amazing how it can still work even in the presence of heavy calcium. You lose a little bit of specificity, but it still works reasonably well. It showed evidence of a severe hemodynamically significant stenosis involving the distal left main. And again, it confirmed that the RCA did not have significant disease. So these findings were discussed at length with the patient and her daughter, and she was directly admitted to the hospital. So I had told them that she would get a cath on Monday, but the daughter really managed to strong arm my partner, who was an interventionalist, into doing a cath on Saturday morning, which he did, which confirmed the presence of a severe distal left main stenosis with good targets for bypass in the LAD diagonal and obtuse marginal branches. She was seen by cardiac surgery later that on Saturday afternoon. She had some further testing done on Sunday, and I actually went for bypass surgery on Monday with a Lima LED, vein graft to OM1 and vein graft to first diagonal. And again, this was all accomplished. Much of this data was gathered within a 90-minute stay at our cardiac evaluation center. So I just wanted to close some take-home points. First is that coronary CTA is the preferred first-line test for stable chest pain in patients without prior obstructive coronary artery disease. Again, this is very much in line with the 2021 ACC/AHA guidelines. Second, our Araneta Spotlight CT scanner is really well suited for this role in an urgent care setting. It's smaller form factor, and a small field of view really lend well to a cardiology practice, particularly in this setting. It still offers excellent image quality, and again, it's cost efficient for the features that it offers. We actually went live with our second Spotlight CT scanner actually in February of this year in our South region. And then we have plans to purchase hopefully a third scanner in 2028. So thank you all for your attention. And after we're done, we'll take some questions. I will stop sharing and then I will turn things back over to Siley.
Thank you so much, Dr. Sujit. That was a fantastic overview and such valuable insight. Now I am excited to introduce you to our next speaker, Dr. Alberto Morales. He will be presenting the topic, Why We Lower LDL But Still Miss Heart Attacks, the case for serial imaging in atherosclerosis. Dr. Morales is a multi-board certified cardiologist based in Tampa with expertise in advanced cardiac imaging and preventive cardiology. As Director of Advanced Cardiac Imaging Fellowship Program at South Tampa Cardiology, he leads training across 7 cardiology programs in the HCA West Florida Division. Dr. Morales is widely recognized for his work in lipidology and cardiovascular prevention and for developing patient-centered strategies to reduce plaque burden and lower cardiovascular risk through early detection and personalized treatment. Dr. Morales, welcome.
Thank you, Thank you, Siley. Thank you, Araneta, for invite. Oops, I think I went too far into my presentation. Let me go back. All right. Well, thank you, Araneta. Thank you, SCCT, for inviting me. Dr. Sujit, very nice presentation, really overviewing the benefits of the Araneta CT scanner and the benefits of an outpatient CT first strategy in the management of stable chest pain. This is my talk, which is why we lower LDL but still miss heart attacks, and some of the reasons behind it. Can you see my presentation? Hold on a second. Uh-oh. Shit.
You're good. We see it.
You see it? I can't see it. Hold on a second. Okay, there we go. Sorry about that. All right. All right, so these are my disclosures and these are the objectives. And I'll be talking about, throughout the case of a patient that I've been managing for the past 11 years and how serial CT has guided the management across this patient. I'll touch on randomized control trials, some of the benefits of it, but also some of the narrow questions that it answers, and how serial CT coupled with AI can really help us really answer what's really going on in our patient. And then we'll touch on that coronary artery disease. Obviously Dr. Sujith did go over on patient 5, a patient who had a lot of plaque and was on high intensity guideline therapy. However, they continued to progress. And so maybe some of the reasons behind why residual risk continues in these patient populations. And so at the end of 2022, we installed an Araneta cardiograph at that time, and we upgraded it to the Spotlight. And you could see all the wonderful benefits. You saw some of the great images on the previous discussion. 560 slice CT scanner, super fast spatial resolution. So really superb image quality. And right off the bat, we noticed that we were able to reduce the contrast by over 50%. We average somewhere between 50 and 60 cc's of contrast per patient. So a really significant reduction going from the hospital scanner to an outpatient scanner. And the most notable drop is in the radiation dose. And what this, and we on average, somewhere between 3 and 4 millisieverts, 3.5 millisieverts of radiation. And what this allowed us to do is really shift the way we manage patients, going from a reactive approach where we're waiting for symptoms, waiting for events, waiting for acute coronary syndrome, to actually tracking and monitoring patients, being proactive, from a reactive to a proactive, answering the question as opposed to looking for who has stenosis, to actually having a method of who has biologically active plaque, going from a cath stent bypass pathway to a personalized see, treat, and see philosophy, where we actually look at disease before it causes events, and we serially track patients to try to prevent events and also identify who is not responding to therapy. And so we're going beyond stenosis here. We're going beyond ischemia. And why is that? There's been a lot of data recently that the majority of heart attacks occur are actually in these non-obstructive plaques. These are plaques that are 40% or less. And why is that? These are lesions that are not significant, typically don't cause symptoms, and obviously are negative on stress testing. And so it's these biologically active plaques. And so it just turns out that we've been looking at this whole thing all wrong from the beginning. And it turns out that plaque burden and plaque morphology is actually the risk of what's going to lead to an event, not stenosis. Stenosis is more in the setting of symptoms. And so, when you couple, coronary CT with AI, and I use Clearly Analytics, I also use Elucid, but you can see Clearly has been our great partner here, and you can actually measure low-risk plaques in the form of calcific stable plaques, all the way up to non-calcified plaques, low attenuation plaques. These are the plaques that tend to rupture. And so when you couple CT with histograms, which is what I call AI plaque analysis, such as Clearly, you can answer a different question. What is the plaque burden? How much plaque does this patient have? What type of plaque do they have? Do they have risky plaque that can rupture? We can characterize this plaque. We can also characterize inflammation around the coronaries, and goes far beyond just measuring who needs a stent and who needs bypass, and into a more personalized preventative therapy. So this is an 11-year case. This is a patient who I actually saw. He was 55 in 2014. He's a very active Navy SEAL, lived an active lifestyle. I think he fell off a ladder and cracked a rib and had some chest pain. They did a CT scan on him in the hospital, and he had some calcium buildup, and he was referred to me by his primary care for this. And what we decided to do was perform a coronary CT angiogram. And at that time, we could see he had some mild plaque in the left main and the LAD. And I pulled the images and I sent them to Clearly so we can get an AI analysis. And what you can see here, this is kind of how we look at it, right? So here we can see some soft plaque, some mixed plaque, and extending into the LAD, you can see some mixed, mostly calcified plaque in the prox LAD. However, when you add the AI to it, now you can light it up, and so you can actually see blue is the calcific plaque, yellow is the non-calcified plaque, red is the low attenuation plaque. This is plaque that is more dangerous, right? And so you can actually measure this amount of plaque, and you get a total plaque amount. You can characterize it, so you get a lot of wealth of information. This is sort of the histology of a plaque and evolution, and you get a more personalized, detailed evaluation of this patient. And you can see Clearly didn't call anything significant plaque here, and I agree. And I believe I called this less than 50% in the prox LAD, this lesion right here, and they called it less than 35%. The left circ and the RCA did not have any significant disease. Clearly has a nice feature called ischemia, which is like FFR, and it's binary, meaning if it's positive, it's going to show up. If it's negative, then it stays blue like this, and there was no ischemia. It gives you a very comprehensive report, and at this time in 2014, I wouldn't have had a report like this. I would have probably stated that he had very mild plaque burden and mild stenosis, but when you look at the actual amount of plaque, he actually had a pretty significant amount, 409 cubic millimeters of total plaque volume. This is a nice metric that you can follow serially in your patients. He had a significant amount of low attenuation plaque. This is the risky plaque. This is that associated with a necrotic core, inflammation, typically associated with a thin cap, and highly likely to rupture. And we have lots of data supporting this. And then these non-calcified plaques could be a mixture of fibrofatty plaque, which are plaques that can also rupture. And then you can get more information as far as percent stenosis, total plaque atheroma volume, etc. So we did what we typically did around that time in 2014. We identified him with non-obstructive coronary artery disease. We put him on an aspirin. We put him on a statin. And we basically followed him once a year. You know, on occasion, maybe we did a stress test here and there, but our goal at that time was very conservative. Let's get your LDL under 100. Let's get you on statin, go see your primary. And, you know, throughout the years, I think we had one lab that was in 2017, a few years later, and his LDL was 92, asymptomatic, doing fantastic. And so, you know, fast forward 9 years later, we get this scanner, and we are now scanning patients who, you know, again, this is not guideline driven. This is personalized care. So patients are actually investing in their care and paying a cash pay fee to identify whether they have coronary artery disease or not. And we offered it to him 9 years later, thinking, you know, you've been on statin therapy. You should be doing very well. Let's just take a peek in and see how you're doing. And lo and behold, he had significant increase in burden of his disease, significant increase in stenotic lesions involving the left main and LAD. And at that time, to me, left main was, hey, we don't mess around with left main. You're going to need a cath. Let's take a closer look. We had labs at that time, and lo and behold, you can look, his LDL was 63, it was below 75. So nothing you would expect different. A1C was 5, BMI was under 30. So, you know, guideline-driven therapy on statins, goal cholesterol values and lab markers have all been met, asymptomatic. Had we not screened, you know, and taken a look, we wouldn't have seen this evolution of progression. So if you look at the scan here, you can kind of see that there's been some progression in stenotic lesions, and you can see this bulky soft plaque involving the distal left main and more extensive remodeling and bulkiness involving the prox LAD. You could see that Clearly went from 0% to 43%. The prox LAD went from 34% to 46%. Again, non-ischemic asymptomatic, doing well, but we offered him a cath, and so when you look at, this I consider this to be the future of cardiology, this comprehensive compare analysis that clearly provides, which gives you real raw data and tells you exactly. You can see he had a total plaque volume of 409. And over a 9-year period, he developed about 319 increase in cubic millimeters of soft plaque, or of total plaque, which translates to about an annualized rate of about 35 cubic millimeters of addition on a yearly basis. You can see a lot of it is non-calcified, and very little calcific turnover, that would be expected on statin therapy. And a significant portion of this low attenuation plaque continued and persisted, as you can see here, over a 9-year period. So we did send him for a cath, and they did IVUS it, and they called it less than 40%. They did not offer him a bypass at that time. They recommended continued aggressive therapy, as we were already doing. And so you could see the dilemma here. You got a gentleman that you're treating aggressively, and yet he's progressing. And the recommendation is more aggressive therapy. So here we go. So we're going to add PCSK9. We added Repatha to his regimen, and we said we're going to shoot for a much lower LDL, and certainly this should stabilize this plaque, right? With our intention, after discussion with the patient, and with a reevaluation, and a serial CT scan a year later to assess response, to see if we finally stabilize his plaque. And you could see after therapy, we got his LDL down to 11, A1C still good. So here's some of the problems with randomized control trials, right? So, when you randomized control trials do a very good job of answering the, safety and net benefit of drug A versus placebo, right? So you get 1,000 group, thousands of patients, you match them for cohorts, you monitor them for 4 or 5 years, and then you count your events. You count how many heart attacks, you count how many deaths, and in that period of time, that 4 or 5 year window, we see if there's a benefit, if there's a separation of the curve. Did drug A beat placebo, right? But the real question is, what happens after that 5-year trial? Do the curves continue to be separated? So it can show, randomized control trials do a very good job. They're the basis of our guidelines. However, they only answer a narrow question. Drug A beats drug placebo over a short period of time, and does that translate to long-term benefit, right? That's the question. Whereas serial CT answers a different question, right? So you can see this is plaque burden up here. And if we have a patient and we do these serial scans over their lifetime, right? And we peek in and we have them on these randomized control, guideline evidence-based drugs, is therapy actually working? If they're actually progressing, then you could say that they're not working in this patient. If it is working, then we should see stabilization or even plaque regression. And so serial CT answers a totally different question. It answers, is this therapy working in my patient? We do the same thing with other types of drugs, such as hypertensive drugs and cholesterol drugs. We get outcomes trials, but then we also check to see if the cholesterol is truly falling. So these are landmark trials. So the question here is, we already know this. These are 3 of the landmark trials. Does statins reduce events in patients with known coronary artery disease? And we have 4S, lipid, and CARE. And if you look at this data, this is excellent data. MACE heart attacks went down by 32%. Heart attacks in lipid went down by 23%. Death rates dropped by 33 and 22. But if you look closely, you can see 431 patients still died over 620, had heart attacks. 182 still died over 256. So these drugs work, they reduce, they shift the curve, but they don't cure you. And so you still have quite a few amount of patients. So if you add up all these studies and look at it over 100 patients, you still have 18 heart attacks versus 14 heart attacks on statin, but you still have 14 heart attacks in patients who are on statins. You still have 10 deaths out of 100, out of 12 deaths who are not on statins. So these drugs, they shift the curve down in a population, but do they answer the question, does this drug work in this particular patient? So the next question is, well, what if we ramp up the high intensity, right? We did that in case 5. We ramped up, put her on high intensity, and we never looked again. 20 years later, this patient's going for bypass surgery, right? So TNT, ideal, prove it, miracle. These are great trials. They were all positive, fantastic outcomes, 20% reduction in heart attacks, really no significant difference in death. And look how many people still had heart attacks, 411 over 463. So we didn't cure the disease, we just shifted the curve down, right? 14% had heart attacks compared to 12. So we had 2 fewer events. Really no significant shift. So adding a statin provides a shift downward, less events, but not a cure. Increasing the statin to maximal intensity, again, no significant change in death, maybe a couple less heart attacks, right? So what if we add PCSK9 or something similar and we reduce the LDL to below 55 and even ApoB under 50, right? Do we get an additional net benefit? So I threw in Vesalis, which is not looking at symptom patients with known CAD. Odyssey and Fourier, these are patients who had known CAD. And look how low we got the LDL 30, ApoB 38, LDL 53, 39 versus LDLs in the 100s on just statins alone, right? And you can see there's a 20% reduction across the board in as far as reducing heart attacks, but no significant major difference in death rates. And you still see a good amount of patients still had heart attacks. So you get an additional 1.5 less heart attacks and really no major shift as far as death rates. And so the problem with randomized control trials is it doesn't answer the blind spot. The blind spot is what happens after the trial ends. Do these curves continue to separate out or do they narrow? Are we only merely delaying the inevitable? Are we slowing the clock down and only to eventually have events at a later point? Right? So we don't really know because we haven't really tracked patients, right? There are many reasons why. A lot of them could be tracked by serial CT, A lot of patients don't have no known diagnosis. And so since we don't screen, and we will have outcome trials that show, that screening is beneficial, and we got some trials in the process and registries, but high plaque burden is part of the reason. We identify these patients way too late, and by that time they're already having a lot of events and inflamed plaque and biologically active plaque. We can identify which plaques are riskier plaques. We can identify who's inflamed already, and we can do a lot of this with serial CT. And then we have other reasons such as high Lp(a), systemic inflammatory diseases, medical noncompliance, or therapeutic inertia, right? We do know that in patients who are on drug therapy, who've had an event, by usually year 10, 12, almost 60% of these patients have already discontinued therapy. There are many factors related to that, and not to belabor the point, we will move on from that. But a lot of reasons why that happens, and part of that is, the loss of the event. The event was so far removed from them. Now they are beyond that, and now they're wondering why are they still taking this drug? No one's shown them an explanation. This is where CT could be beneficial in reamping the focus as to why they should. And we do that in our clinic all the time. So let's go back to our patient. So we rescanned him a year later. We got him on Repatha. I showed you the LDL was 14, and we rescanned him, and he had significant increase again in his left main and in his LAD. And not only that, we found a thrombus in his left atrial appendage. Again, asymptomatic, no palpitations, asymptomatic. We ended up diagnosing him with AFib, and we put him on a blood thinner. But you could see the significant progression in his plaque. So despite being on Repatha, despite being on high intensity statin, he's continuing to progress. Left main went from 0, 43, now 50%. Now he's globally ischemic. Again, he's asymptomatic. The prox-LAD has progressed, and he's globally ischemic now. So what do you do in this patient, right? And look, the right coronary artery and the left circumflex has not changed. So all these changes are occurring in one vessel. right? So now we can really see the pattern here. We got over a 9-year period, he increased at a rate of about 35 cubic millimeters. And in 1 year, look at this, 1 year, he increased by almost half of what he did in 9 years, right? 172 cubic millimeters of increase. And a majority of that is non-calcified plaque. Very little turnover in calcium. And so you could see in 2014, you could see the progression in 2023, and now you can see this significant progression in the LAD. This is scary. We're putting patients on aggressive medical therapy, and we don't really know what's going on underneath until we look. And if you look, you might see something like this, and this might change the way you think. So if you think about it, we've decreased his LDL by almost 86% down to 11, and yet he's still progressing. His BMI is not terrible, so what do? So we have him on Lipitor 40, Repatha. He's got a clot now. Had we not looked, we wouldn't have identified him with AFib. So we put him on colchicine, we put him on Xarelto, we bumped up his Lipitor to 80, and we decided to check all these markers, right? And we scanned him 6 months later to identify resolution of this thrombus. And you can see the left main now has continued to progress now, despite adding all these excess drugs, right? It says LP little a is not a player, A1C is not a player, ApoB is not a player, LDL is 13. Highly sensitive CRP is not a player. Weight, he lost, I think 16 pounds, continues to be exercising without any symptoms, and yet he's continuing to progress. And if you look closely, you can see he is really brewing low attenuation plaque inside this left main. This is very, very risky, and his percent stenosis has continued to go up. Low and globally ischemic here, right? This is not very good. Obviously, we're having discussions about another cath. He refuses at this time, and no significant change in the left circ, no significant change in the right coronary artery. And now you can see this full breadth of data, right? Of progression, right? And in 6 months, you could see he's increased by 85 cubic millimeters of plaque. So despite aggressive medical therapy, he continues to build plaque, he continues to remodel, he continues to become, more stenotic. And so this is guideline evidence therapy. I don't think you could add any more drugs at this point. So obviously we're having conversations with him about bypass. He doesn't want another cath. He wants another option. And so, this is not a semaglutide or an Ozempic talk. However, we've seen significant benefits in a lot of our patients as we're tracking plaque. So we did decide to go ahead and start microdosing for semaglutide. Again, this is off-label use. This is not a patient who's diabetic. This is not a patient who's overweight. This is not a patient who you would normally start. His body weight is actually good. He's a tall gentleman. So now we have him on Lipitor 80. We have him on Repatha 140. He's on colchicine. He's on Xarelto. And we're starting GLP-1 at microdosing with the intent of this is it. This is, if you have any symptoms, we're sending you for a cath. If this doesn't work, we're sending you for a cath after careful discussion with the patient. So we rescan him 6 months later. The clot is still resolved. All his numbers look fantastic. His A1C, his LP little a, his LDL is still perfect. And for the first time, we see some improvement in his morphology. His left main is starting to shrink a little bit. A lot of the soft plaque and low attenuation plaque is also starting to resolve. And as you look closely, you can see that this lipid-rich necrotic core, low attenuation plaque is starting to get reduced. The percent stenosis has dropped from 51% down to 46. Global ischemia has resolved, and his other arteries have continued to remain unchanged. And for the first time, we're starting to see green, right? So throughout the life of serial monitoring in this patient, you can see he's continued to increase and build plaque. And all along the way, we've optimized and adjusted management to try to tame and neutralize this yearly plaque progression. And for the first time, we're seeing green where he is no longer building plaque, and he's also eliminating soft plaque, and low attenuation plaque has started to reduce from 27 to 21. So let's kind of go through this, and you can see the progression, the remodeling, the brewing of the low attenuation plaque, and then finally with picking the correct regimen that works in our patient, you can see the regression of plaque volume and low attenuation. And so for take-home points, I think, randomized controlled trials are the basis of our guidelines. It tells us what works on average in a population. The question is, does it answer what's going on in your individual patient? The problem with these trials is once the clock stops, we don't know what happens after. Serial CT with AI, tells us what's happening in our individual patient. See, treat, see again. It allows us to identify non-responders. And then obviously residual risk is expected in coronary artery disease. It is not one pathway. It is not cholesterol. It is not start a statin and never look again. There are multiple pathways involved in development of coronary artery disease. Also, it is not linear. Some patients rapidly accelerate in progression. And so it's important to identify who is progressing rapidly, who is about to have an event, and what can we do to avoid an event. And with that, I will end my presentation and we'll take on some questions. And sorry for going over time. Thank you very much.
Thank you so much, Dr. Morales. We would like to open the floor for questions. If you have any, you will see the Q&A session in the chat. Please go ahead and ask your questions. I already see a couple of questions requesting for presentations. So our SCCT team will be sending you a recording tomorrow, and you can visit erineta.com sometime next week, and you will see the recording as well as the presentations uploaded to our webinars and presentation pages. And there is a comment that I read. It says that, can you touch on radiation dose concerns for serial scanning?
I think that's a question for me for serial CT scanning. So I think when you're going to start a program where you're screening and you're offering cash pay options for patients, you need to make sure that your radiation dose is very appropriate. And for us, we decided to go with an Araneta Spotlight CT scanner because the radiation is significantly decreased from hospital. So you should not be doing serial CT scanning, in my opinion, on patients that on scanners that give high radiation. And so you really need to have a radiation dose under 3, and when we're doing these serial CT scans, we're not doing calcium scoring because we have all the information already available as far as previous. We also have the quantifiable calcific cubic millimeter of plaque. And so most of our patients, this particular gentleman, his first scan was done at the hospital, and I believe I looked at the radiation. It was somewhere around 18 millisieverts of radiation at that time. And all the subsequent scans together combined for a total of 12 millisieverts. So one scan, 18 millisieverts. The following 4 scans or 3 scans, I believe, was a total of 12 millisieverts. So you can imagine how many total scans it would take to equal one scan on a 64 slice. So again, you need very low radiation, and obviously this is not something that's covered. Patients have to buy in. This is personalized care, and so a very different discussion than Dr. Sujit.
Sally, I wanted to comment on that too. First of all, Dr. Morales, fantastic presentation, very sobering presentation, actually. It shows the power of CT, but also the danger of relying on biomarkers alone to track disease progression, where we can lull ourselves into this false sense of confidence that we've got things locked down, when in fact the disease is aggressively progressing and we're just not looking. So yeah, I think the most exciting stuff we're doing in coronary CTA is serial plaque analysis to track disease longitudinally, and you're really well ahead of the curve, with things. And yeah, as Dr. Morales highlighted, the Spotlight scanner is great because it's smaller form factor, less radiation. Key issue, as we do these studies longitudinally, since we're not calcium scoring, the amount of radiation Dr. Morales is administering is comparable to a calcium score. And I mean, I see many people who for reasons I'm not entirely sure, we'll do serial calcium scores on patients who are getting statin therapy. That's hard to justify. Where Dr. Morales' approach makes perfect sense because we're actually seeing plaque on a very granular level and watching it progress. So really neat, and I think it's going to be a key issue going forwards. As we do serial CT.
Thank you. There is a comment about, I think this is when you were presenting, Dr. Morales, you have not used ezetimibe, and this is now mainly mainline after high affinity statins before going to Repatha. Moderate statin plus ezetimibe gets more people to goal than progressive increases in statin doses.
Yeah, so in the context of, trying to shorten my presentation, I did remove the Zetia, studies on there. The studies were at best, modest and not super overwhelmingly better than PCSK9. There was really no change in mortality and maybe a 1% benefit compared to adding to statins when you take all the studies combined together. But yes, Zetia is one of the cornerstones. A lot of my patients we have on Zetia, they continue to progress on serial CTs. So personally, I've bypassed Zetia use and I go straight to PCSK9s. I find that PCSK9s tend to work better, and I believe it's not in the LDL reduction, but it's probably in the partial Lp(a) reduction is where I see the benefit.
And Dr. Morales, that case you presented, their LDL was almost zero, essentially, by the
Yeah.
time you get them on therapy, yet they were still progressing. So clearly some other pathway, was driving their atherosclerosis.
Exactly, and we're discovering new pathways, and when I first started doing serial CT about a year and a half to 2 years ago, we've scanned over, I think we have over 1,200 compares now, of which the majority of those are 2 scans. We have 3 scans. You saw one with 4 or 5 scans. We've got a wealth of knowledge here, and what I'm discovering is that there are beyond pathways of just cholesterol. I have patients who have LDLs in the 2 range, and that they continue to progress. And there may be reasons behind that, such as high Lp(a), whether they're a smoker, hypertensive, inflammation. What we have discovered is that these GLP-1s tend to tame that other aspect, and there may be other pathways involved, and we're learning, and we've created a registry to really understand this whole pathway, and we've teamed up with Clearly to really understand this whole concept of why is it that these guideline therapies only work in a subset of patients. They don't work on everybody. And it isn't until you look that you realize, oh my goodness, this what I would have thought worked in this patient is only working in that patient, but not this patient. So I think there's some trials out there. There's some registries. There's Transform trial. There's Scott Hart 2. I have a registry, and so we're going to be able to answer this question probably within the next 2 to 3 years.
Thank you, Dr. Morales. Unfortunately, we are running short on time. So if we did not get to any of your questions, please write directly to us at marketing@arineta.com, and we'll make sure I personally answer those questions on behalf of Dr. Morales and Dr. Sujit. They will be getting these questions also. And I just want to say thank you all so much for joining us today. I hope you found this session useful. And just a quick reminder for everyone, Arineta team will be at San Diego this July for the SCCT meeting. So come stop by and say hello to us. Thank you.
Thank you, Siley.
Thank you.
Thank you, everybody.